Dr. Benedetto. He is an expert in EUS and EUS intervention, and he will give us a talk about comparison between EUS biliary drainage and the PTC for palliative patient with unresectable pancreatic cancer.
Thank you, Hamad, for this kind invitation that I hope is the start of a future scientific collaboration. Thank you, dear moderator. Thank you, Hamad. Thank you, Nawaf. They are preparing for the speech. Okay, our talk is about biliary drainage by EUS compared to percutaneous drainage in palliative drainage in unresectable malignancies. What we have to study about, we are talking about the setting and current biliary drainage approach, the EUS biliary drainage and the percutaneous drainage, when to do it, and the comparison of clinical outcomes, technical and clinical success, with the quality of life evaluation. This is, for me, the most important point that we have to discuss at the end of the talk. Then, we know which disease are the causes of jaundice, as pancreatic cancer, cholangiocarcinoma, biliary cancer, metastatic disease, and lymphoma. But all of these pathologies causing malignant biliary obstruction causes the same symptomology, like jaundice, pain, itching, acute cholangitis, with a poor quality of life and delayed tumor treatment. Then a nearly and efficient treatment of obstructive jaundice is mandatory. We know that about, if we refer to our published data, about 5 to 10% of ERCP can fail in malignant biliary obstruction for different reasons, because of duodenal stricture, because of papillary involvement. Then, if the ERCP fail, we have to do a percutaneous drainage or a biliary drainage. There are different reasons because why an ERCP can fail. The biliary drainage by EUS was, for the first time, it was published by our group, that is feasible as first-line treatment also for after year failed ERCP, and with a good technical and clinical success and low adverse events rate if compared to ERCP. And this year we published a very big study, international study worldwide, with about 300 patients, showing as the first line treatment by therapeutic EUS should be possible. But with the similar results if compared to gallbladder or choledochal drainage. Anyway, but what we have to choose between EUS and percutaneous drainage if ERCP fails? What? We know as the echoendoscopic drainage should be by transgastric or transduodenal access, and please prefer the transduodenal access when it's possible, and should be done by hepaticogastrostomy or choledochoduodenostomy, or by gallbladder drainage by stomach or from the duodenum. Then percutaneous drainage should be or external or internal. This is very, very good issue that we discuss with our interventional radiologists, because we want the internal drainage if it's possible as first step. Anyway, this is a photo for one of the first drainage by metal stent with before the use of the luminal opposing stent, metal stent. We evaluated the technical success, the clinical success, the procedure-related adverse events and mortality, the reintervention because of patency and the stent dysfunction, the hospital length of stay and the resource use, and the patient's quality of life, the most important point. The evidence that we have in the meta-analysis show the comparable technical success between biliary drainage by EUS and percutaneous one, but the EUS biliary drainage is associated with higher clinical success and lower adverse events in several analyses. Moreover, the EUS biliary drainage is linked to fewer intervention and short hospital stays. This meta-analysis of 2022 showed us the adverse events are measured for percutaneous drainage, like cholangitis, stent dislocation, stent obstruction, and the reintervention rate are higher for percutaneous drainage, translating a poorer quality of life. In this meta-analysis of that we showed before, we show us the need of reintervention is very higher in percutaneous group, and the death is higher for the patients treated by percutaneous approach because of recurrent cholangitis that falls on the DIT for the patients. Endoscopic ultrasound guided biliary drainage is generally to prefer between percutaneous drainage because the technical success is very similar between the two procedures, but the clinical success is about half time more for EUS drainage, different to percutaneous, with less rate of adverse event at 24 hours. Similar data were published in this meta-analysis because procedure-related adverse events also are showed very less if compared to, or for EUS, if compared to percutaneous drainage, and the reintervention is about 2 times less for EUS. Anyway, the direct assessment and comparison of quality of life at baseline at 1 month and 3 months between EUS and percutaneous drainage, there are no significant difference in quality of life, but we have to remember that patients with percutaneous drainage has an external catheter. This should be very uncomfortable for the patients because we have to remind that are clinical and oncological patients with a poor expectancy. The quality of life it's depend from the catheter because and not only for the catheter because patients with the percutaneous drainage should have a major rate of reintervention for cholangitis than the EUS biliary drainage with internal drainage as to prefer to the percutaneous one. And the randomized clinical trial and prospective studies report fewer visits and reintervention after echoendoscopic biliary drainage, likely improving end-of-life quality of life. The adverse events between the two procedures are a little bit different because for the percutaneous one, we can have catheter dislodgement, cholangitis, bleeding, pain, external care issue, and for biliary drainage, we should have leak, peritonitis, emigration, pneumoperitoneum, and also stent occlusion. Overall, the adverse events are frequently lower in biliary drainage by EUS than the percutaneous one, with lower reintervention. What about hospitality cost? The echoendoscopic biliary drainage often is associated with a very low hospital stay. Generally, patients drained by EUS can go at home the day after procedure, and the lower reintervention rate after echoendoscopic biliary drainage are translated in fewer hospital visit and procedure that can be translated in a reduction of the cost. Then cost effectiveness varies by center because it's up for local expertise, the complexity, the initial technical complexity, the need of repeated intervention. The drainage method affects palliation and access to chemotherapy because timing is very important because more is short the timing for the treatment of jaundice and better is the oncological response of the patients. Despite there are non-consistent evidence that the drainage route by EUS or percutaneous one change the survival in unresectable malignancy. Then the biliary drainage may facilitate the EUS biliary drainage may facilitate the internally biliary access and earlier chemotherapy in some cohort of patients published in literature. Which is the best algorithm that we have to use in case of a failed ERCP? If in our center there is an therapeutic echoendoscopist, okay, EUS biliary drainage should be to prefer. But if we have not, we can do percutaneous drainage, but there is another possibility that for me is very important. Please refer the patients to a referral center, because there is no need to catch our patients in our center, because if we have no competence for the patients, we have to send the patients to the referral center, because the goal is not the procedure, the goal is the patients. Practical consideration. Biliary drainage require experienced endoscopists. Center should audit outcomes and adverse events. In our center, every week we review the cases to see if we have some adverse events, if everything was done correctly. And the luminal opposing metal stents and dedicated accessories improve the technical success. Antibiotic prophylaxis, careful tract dilation, and appropriate stent selection can reduce the complication. That's the way an endoscopist, an expert endoscopist, should reduce the adverse event in this kind of patients. And the coordination with oncology and multidisciplinary approach, interventional radiology, improve the patient's centered care. What's the limitation about? Heterogeneity across the study. Few large randomized trials, many observational series meta-analysis of heterogeneous data, limited dedicated quality of life instruments and standardized time points in many studies, but we need of prospective RCT study that focusing on the quality of life of the patients, because I want to remember you that the goal is the patients, not the procedure. Then EUS-biliary drainage is an effective alternative to percutaneous one after failed ERCP with comparable technical success. Evidence suggests that EUS-biliary drainage has higher clinical success, lower adverse event, and fewer reintervention, improved quality of life measures tied to internal drainage. And we have to choose the biliary drainage by EUS when local expertise is present, the devices are available, and use percutaneous drainage only if therapeutic EUS is not available. Thank you for your attention, and visit us in Milan when you want.
Thank you, Benedetto. So we save some time, so we are open the floor now for the questions. So, Matt.
So when you mentioned about complication, you said stent blockage, stent migration, pneumoperitoneum, peritonitis, all with this EUS, and you said expertise in EUS-guided drainage. So that's 2 points. The PTC, at least when it is blockage, and we bring the patient, we do some flushing, and we do some, and the chance for migration and is that something favor when you say expert biliary EUS expert? I mean not the usual EUS drainage, someone who is doing this very frequently, right? Otherwise complication will happen. Stent occlusion is easier to deal with it with PTC. Am I right?
The migration stent, it's this is a very big issue, big. First of all, it's up from the site. Second, from the stent, because there are we have three big stent, luminal positional stent using in therapeutic EUS, and there is some stent that present a high risk of migration than the other one. But for example, I don't not use one of these two stents because have a high risk of migration. And the second time, especially in patients with malignant biliary obstruction, I prefer, if I drain the gallbladder or the choledoco or the common bile duct through the duodenum, to place a duodenal stent, not to do an EUS-GJ, because if you have a subocclusion of the duodenal wall, if you do the EUS-GJ, the food can impact inside the bulb. If you place a duodenal stent, you restore the possibility of the food to go down. And the objective is that with the mesh of the duodenal stent, you should cover the luminal posing metal stent when it's possible, to avoid the food impaction and the occlusion. About the migration is very rare, because oncological patients, because when today we are speaking about patients unfit for surgery, then if you put a luminal opposing metal stent in patients unfit for surgery, then the life expectancy should be 3 to 6 months generally, no more than this. And in that period, in that months, is very difficult a migration. Second, I agree with you that you say for percutaneous drainage you can flush, you can is easy to open the drainage. The other side that 10 French catheters, 12 French catheters should be more frequent occluded than a luminal posing metal stent. One of our discussion with the interventional radiologists in our center is to place direct a metal stent if they have to perform percutaneous drainage, because if our ERCP fails, because ERCP can fails, and there is the possibility for different reasons to place a percutaneous drainage because EUS is not possible for any reason, the placement of internal drainage should be preferred.
So just one question.
Was just one comment.
Yes, go ahead, Dr. Hussein.
Okay.
So, okay.
Sure.
So there are two parts of your questions. One is comparison between the EUS bioduct drainage and the PTC, like their side effects and their function of those and usefulness of those. Second part of the question is availability and expertise. So I'm going to go with the previous one first. So when the expertise is available, we are comparing those two, EUS-guided biliary drainage and PTC. PTC is well established, no question about that. It causes pain, tube hanging out. Patients don't like it. It occludes very frequently. It needs to go over and over. High risk of over and over need to repeat. High risk of infection. On the other side, if you put from inside, the risk of EUS-guided biliary drainage, again, when the expertise is available, is low. It's keep decreasing less than 10% overall risk. It stays open based on what you kind of stent you put in. I think as we move along, I'll have some cases, we'll talk more about that. But the lumen opposing metal stent occludes more frequently as compared to the tubular. If you do it from the duodenum, it occludes more frequently as compared to the from the stomach, hepatogastrostomy. So those are two different things, but overall patient tolerate EUS-guided much better. There's a less risk of blockage of those, less risk of migration, less chances of repeating over and over. So if the expertise is available, we would, in this day, we would prefer EUS-guided. Now, the second part of the question is the expertise available? Majority of the places, they don't have that available EUS-guided. So in those cases, PTC is well established. You should go for PTC.
Thank you.